Good morning. My name is Eduardo Gotuso. I am a professor of medicine at Cayetano Heredia University in Lima and director of the Tropical Medicine Institute Alexander von Humboldt in Cayetano Heredia University in Lima. For me, it's a pleasure to be here, and I would like to thank you to organize committee to give me the opportunity to be co-chair this session and participate during the Congress. As you know, in the last 30 years, tropical medicine have a lot of problems with the new drugs. You know, in the pharmacology, we know there are more than 2,000 new products. Only 20 are coming from tropical medicine. But the main number of these is coming from the animals. It's the veterinary medicine who discovered triclavendazole, ivermectin, other drugs. But they are not a specific drug when you have different diseases in the tropics. Usually we are using drugs from 50 years in Chagas, in trypanosoma, and then when we have resistance because we have only one drug, we have a huge problem in our countries. And it's very important to discuss about the discovery of new drugs from tropical medicine, the neglected diseases in the medicine world. And today we have the opportunity to discuss this option. I would like to share this session with Professor Marlene Boulard from the Tropical Medicine Institute. And I would like to introduce the first speaker. Each speaker has 25 minutes, and then we try to say a few minutes from comments or questions. The first speaker is Dr. Julio Martin. He is the head of the kinetoplastic biology discovered in the GSK in Spain. Dr. Martin is a PhD in biology, and he also worked in the past and discovered a new antimicrobial drugs in the GSK. And he will present today bring pharma and academia toward drug discovery for disease in the developing countries. Dr. Martin.
Thank you very much, Eduardo, for the introduction, and to the organizing committee, of course, for the kind invitation to be here, and to all of you for making the heroic effort of being here after the dinner last night, so enjoyable. So I second Eduardo's words. I think that the society of this century, and in particular the so-called developed world, has a responsibility and a commitment that we have to face all together, and is the discovery and development of new medicines to treat the population and the patients that are suffering of diseases in the developing world. So we are going to bring and share with you today is a kind of case studies, how we are facing this challenge in GSK, how we organize and where we are delivering so far. But I wanted to start, I think it was a good opportunity to give you an insight into the landscape of R&D in the pharmaceutical industry, the challenges that we are facing, because otherwise it will be difficult to understand what's the context and how tough it is to invest in discovery of medicines for the developing world. So I'll try to make this working. So this has been an overused slide, but I think it's one of the best illustrations or plots to give an idea on the decline of productivity of R&D. Is the Aaron's law. So that means that every 9 years, the productivity in R&D, the number of drugs that are developed per unit of money, is divided by 2. So in other words, the cost of a drug is doubling every 9 years. So the plot is until 2010. So what's happening since then? So there are some signs for hope. Here you see that there has been a stop in the investment of R&D without a decline in the number of drugs. That means that the cost of a drug is in a steady state, more or less, hopefully, and it's around $2 billion, so $2,000 million, about that. So figures are not absolute. To have a meaning, it has to be relative to something. So how large is $1.8 billion? So it's as large as the gross domestic product of some countries. So as you see in this example. So it's a huge amount of money. But it's not just a question of money, it's also the length in the turnaround. So it takes 10 to 15 years, and it's also dramatic, the attrition. So 10% of the candidates that get into phase 1, in the first clinical trial, only 10% of those will get into the market. It will become a medicine with access to the patients, and only 1/3 of those will make the amount of money to return the investment of that. So that means, So that means that most of the effort, the time, and the money is spent in projects that fail, and that's included in the figure I gave you about the cost of drugs. Why are we failing? So there are different ways of approaching this, but it's about not making the right decisions at the right time. So it's about, for instance, not making the right decisions about the target, which is relevant, not making the right decision about the molecule. And this is my humble opinion, is that we are confused by the huge amount of data and information that we get out of all the biological tests, from the in vitro to the clinical trials, or everything. So we are somehow lost in the translation of all this information, and we don't know quite well how to navigate all the chemical space to convert a poor to medium molecule into a medicine. So there are many barriers to overcome. So I told you that phase 1 attrition from phase 1 is 90%, which is huge. Why are we failing, and where are we failing? So this it was 500 years ago, more or less, that Paracelsus already said that everything is a poison. So what makes a poison different to a drug is the dose. So at the end of the day, it's a balance about therapeutic advantage and adverse effects and toxicity. So let's have a look at why the projects are failing, or the products are failing in clinical trials. So this is just I draw your attention only to the blue chart, to the blue bars. So these are new chemical entities, phase 3, and you see that efficacy is the major reason for rather than safety. So we are not so bad in predicting safety. We make very badly in predicting efficacy in phase 3, which is already well advanced. If you have a look at phase 2, it's more or less the same. It's efficacy versus safety here. Okay, so that's the landscape. So we are in the middle of a perfect storm in R&D in pharma. So we have the pressure of the patient. We have to focus on the patient. So there is an urgent unmet medical need, but the payers are only ready now to pay for something that makes a difference. So it's not about me too drugs that it was in the past. So the legislators are putting more and more demand on the safety of the drugs. So the barrier is rising. So the investors, So the investors believe that they can get better return on the investment, maybe by investing in other sectors, in other areas. We had the tendency in the past of overrunning the projects. Actually, there is now incentive in many of the pharmas to stop projects rather than to speed up projects, because it's difficult once you have reached a certain level of investment to stop that and recognize that there is not a way out is tough. So, and the researchers, I'm a researcher, by the way, so we are also frustrated because of the attrition, and because all the expectations that came out from the new technologies, the high throughput technologies, genomics, combinatorial chemistry, have not really delivered so much, at least as expected, right? So this is the landscape. So how we can tackle this? I mean, how can a pharmaceutical company to invest now in an area, diseases of the developing world? Well, there is no return on investment because the payers, the patients will not be able to pay. Otherwise, I mean, if you expect that, you live in a dream. So that's not going to happen. So we have to invent a new model. So that's what I'm going to describe to you. Is what GSK has been doing so far. So I'm going to describe why GSK is involved in this field, and I said commitment to the global health, genuine commitment to global health. So I'm going to give you some insight into how we are organized, how we operate, and some of the deliverables. So now by neglected tropical diseases, I'm focusing now in infectious diseases, contagious diseases, rather than non-communicable diseases. And within these diseases, there are two main leagues. It's the Premier League, not only in terms of funding, but also, of course, in terms of burden and implications. So the Premier League is malaria, tuberculosis, and HIV. Here you have, my goodness. Here you have amount of money. The scale is completely different. Maybe you cannot read it. And here you have the other league. It was the NTDs, the neglected tropical diseases, the infectious tropical diseases. So, but it was maybe 10 years ago. So almost it was 100-fold the amount of funding achieved by malaria, HIV, and TB in comparison with neglected tropical diseases. But it's not only that. It's that if you break down this pool, you don't have, of course, one single disease. You have 10, 20 different diseases. And I mean, you are not going to develop one single drug for all the diseases. That means that all their efforts have to be spread out, so all the diseases. So if you divide 100 by 10 or 20, you can figure out the tiny amount of money that this has been invested and spent in each of these diseases. Not only that, so we have to be very flexible and nimble to react to the demands of the society. So this is a complex cartoon. Maybe you cannot read it, but each circle is a decade from 19th century, and you see different diseases, infectious diseases around the circle. And these are the bars. The length of the bar is the number of reports in the US. And the red are deaths. So you can see that this is dynamic, and we have to react to changes, okay? So we cannot stick to one single disease because the amount of money is very limited. So if we focus more now on the GSK efforts, GSK is working on in discovery of new drugs for malaria, tuberculosis, and kinetoplastic diseases. I'll give you more details later on. But of course, there is an unmet medical need of urgency for these diseases. Here is the burden of kinetoplastic diseases and malaria. And malaria, and you can see by far malaria, and the burden of malaria, as you all know, is much higher. So we have almost more than 3,000 million people at risk of being infected by these diseases. We have around 1 million of deaths of malaria, 400 million cases every year. So it's dramatic. As you can see, and related with the amount of funds, the funding that are receiving, the kinetoplastic diseases as lower, much lower, but the number of cases and deaths and the economic burden is not insignificant at all. So yes, there is an unmet medical need that the pharmaceutical industry have to fill. So GSK is committed to the global health, and we want to discover innovative medicines. It's not just a program of donations. So we want to discover new medicines. So we are second to none within the company if you compare with other areas like oncology, immunoinflammation, or diabetes, in terms of how we manage our operations and the quality of our operations. So there is no doubt of that. As a difference, we have recognized that there are no return on investments. So there's something that we have to give up. So we don't seek commercial return on that. And once you recognize that, you realize that you have to invent a new model of operation. I don't want to use the word business model because this is not about business, but a new operational model, and that's what I want to describe with you. It's a model based on partnership. I mean, it's something that we cannot do alone. We don't want to do by ourselves. So we are going to fill a gap. We are not going to reinvent the wheel, and we look for partnerships. What we have implemented, so we are part of the London Declaration that maybe you already know. And this is the model. We are divided into three discovery units. One specialized in malaria, the second one in TB, the third one in kinetoplastics. In kinetoplastics, we work in visceral leishmaniasis and Chagas disease, the American trypanosomiasis. And we have a model based on collaborations. Each balloon bubble here is a collaboration, and everything is supported by the central services of the company as any other therapeutic area in GSK. We are a center established in 15 years ago. We are 150 people in nearby Madrid in Spain. So our model of operation is based in open innovation and in three main pillars. So the first one is the patent pool. So we are doing is to put in a pool of patents, which is not managed by GSK. It's managed by an independent organization, WIPO. So all the intellectual property created around these drugs for the developing countries, as listed by the UN. And we invite all our partners to do the same, of course. The second pillar is the open lab. So we are opening our infrastructures, our labs, to principal investigators that come with their projects and develop hand-to-hand with us there in our facilities in Spain their own projects. So they are going to keep the ownership, and visiting scientists are coming to work with our researchers and scientists there. So a foundation has been created. It's a charity. It's based in the UK, and of course has an independent governing board. By the way, yesterday we watched the film by Peter Piot. So it's for us it's an honor that Peter Piot is one of the members of the governing board of the Open Lab, Truscantos Open Lab Foundation since July this year. So this is the concept of the Open Lab, is to build a bridge between the academic research, principal investigators with their projects, and the pharmaceutical industry in a common scenario, in a common geographical space, if you want, which are our facilities in Tres Cantos. So we have been running since 2011. We have received already more than 75 scientists, 50 projects, and this is delivering. So this is in a steady state already, and I give you some indicators that say that this is delivering. So in terms of the breakdown of the kind of project that we are receiving, in terms of therapeutic areas, TB is taking, there's a bias for TB projects, although the balance is not so bad. So in terms of geographic distribution of the submissions of the applications, we would like to have more from the endemic areas, which is very little if you compare with the developed well. And in terms of kinds of projects, we would like to feel more the later phases of discovery. So far has been about identification of early compounds or development of tools. We are not limited to academia within the Open Lab project or concept. We are also invite companies, and we have a collaboration with companies, for instance, with the Open Innovation Drug Discovery Initiative led by Eli Lilly. So we collaborate with them as well. And it's not just for projects funded by the Tres Cantos Open Lab Foundation. It's also, we are also members of and participate in different consortia funded by the European Union, for instance. The third pillar was about open source. So this started with the anti-malaria set, published several years ago already, and followed up by the tuberculosis set. And this is the very recent, brand new, it's 2 years old, set of anti-kinetoplastids compounds. But the concept is the same. What we have done is, in collaboration with partners, Dundee University, the CSIC, there's the National Research Council in Spain, NYU, Northeastern. So we have screened the whole collection of compounds of GSK, which is close to 2 million compounds, randomly, through against the three parasites, the three protozoan, the kinetoplastic protozoan. So T. brucei, T. crucei, and Leishmania donovanae. And as a result of that, we have assembled around 600 compounds, 200 for each of the three diseases. We have high quality compounds, early compounds. They have not been tested in vivo animal models, for instance, so far. But we think that it would be a good starting point for principal investigators to leverage their research with tool compounds, trying to match chemistry and biology. So far, we have received more than 30 requests. One paper has already been published about a new target, or known target for a new compound. So we are very excited about that, and we expect more coming up. So what's the measure of success? So there's the question, is this model delivering? We believe so, we believe so. One of the measures of success for sure, and the main one, is to fill the pipeline, to fill and grow the pipeline of drugs. We are here to develop new medicines, as I said. So this is, I don't intend you to read, it's impossible to read it, but these sectors are coming from early discovery to clinical trials, proof of concept. Each spot is a project, is an asset. So, and you see that we are populating the different sectors from early phases projects into clinical trials. That's one measure of success. So we believe that we are delivering. But the other is, there are others. One is that our principal investigators that collaborate with us can raise funds based on the discoveries that we have made together. So that's another indication of the open lab concept and this bridge between academia and pharma. And yes, we have also raised some funding for them. And the last is not least is the reputation of the companies, building trust on GSK in the external world. This is just an indicator. It's a report. It's an access to medicines report index. And last year, and we are first. We are leading the score in R&D with a special mention to the concept of the open innovation in the DDW. This is so that they're overping well. So just to finish, to wrap up, just a few personal reflections based on my experience over the last 7 years, more or less, collaborating with people in academia, with other companies within this umbrella of the open innovation. And some basic principles that I think that should guide these collaborations and this partnership. The first one is bridging cultures. So we have to recognize that academia and industry comes from Stereotypes maybe already old, at least we have to try to make them old. Stereotypes which are divergent. So science is more about transformation, disruptive transformation, whereas the industry is more based in business, is more based in operational excellence. So it's more about return, protection, ownership. Science is more about investment, share, and partnership. Of course, these are stereotypes. These are paradigms that we need to break down. But having people that recognize this difference and trying to reach a meeting point in the middle is fundamental for the success of the teamwork. The second is about sharing risks and sharing rewards. A collaboration is not a kind of CRO relationship. It's not the pharma industry which is putting the money and pay and is waiting for the results. We have to share risks and we have to share rewards. It's a win-to-win kind of relationship. And we have to recognize that also that there's not one single model. I mean, I'm sure that we will be able to find a place in all the spectrum of different collaborations, from having to giving, sharing. So there is a place where to find this. And the main roadblock, one of the main roadblocks, is the IP protection, is IP. In the disease of the developing world, and the WIPO and the patent pool is easier, because I mean we invite to give up this and to give all the inventions away. But if you move outside there, and there are some of the partners that see commercial return, this is a major roadblock. It's about creating a mutual purpose. And last, and I'm going to stop here, is building trust. So building trust is about investing in time, in energy, in the teams from the two collaborators, from the two sides, in meeting this point, reaching these commonalities, and you have to have this mindset in all the members of the teams. Corporations, there are culture in the corporations, but at the end of the day, you have to play the ball on the pitch, and it's there where the success is found. So I'm going to stop here. I don't know if we have time for some question, and I want to remind all of us that we should not forget the people really suffering from these diseases. They should not be the neglected people. Thank you very much.
Thank you. Thank you very much, Dr. Martin. We will take questions at the end if we manage to have a few minutes at the end of the session. So I would like to call our second speaker, Dr. Patricia Kingori. She is a Wellcome Trust Fellow, and she's a lecturer at the Ethox Center in the University of Oxford. Her background is sociology, and she works on the sociology of science and medicine with a special interest in ethics. So she focuses on how frontline health workers view, value, and experience health research and health in general. up to health system research. So Seye, he is an MD, he qualified in 2007 from Alo University in Nigeria. He first practiced in a rural community as a doctor, then joined academics, became a research fellow at the National Primary Healthcare Development Agency. In 2010, he was part of the initiative Emerging Voices for Global Health. In 2016, he was awarded a PhD in health system research from the University of Sydney, where he's currently a lecturer. And he's also editor-in-chief of the journal BMG Global Health. So Seye, you have the floor.
Thank you very much. And I thought I'd start by saying thank you to the organizers of this conference for inviting me and for having me address you this morning. My first impression when I saw the title of the conference was how which button? Okay. Yeah, good. Thank you. Yeah, my first impression when I saw the title of the conference was how delightfully quaint, and that was because people of my generation no longer refer to what they do in terms of tropical medicine and international health. I thought that was a long shelved description of the work that we do, and that we now often describe what we do as global health. And I thought that was interesting, but in spite of the fact that I had assumed that everyone thought of what we do as global health, I was I found it difficult to define global health a couple of years ago when I was appointed the editor-in-chief of BMJ Global Health. It was a new journal, I was the first editor, and I sort of had to define what global health meant in order to define the remit of the journal. And I struggled to actually come up with a meaningful, comprehensive definition of what global health was. And so, like people in my generation tend to do, I looked up what global health might mean in a blog. And this blog was written by former editor of the BMJ, Richard Smith, who admittedly was channeling Peter Piot in this blog. And he gave a series of definitions of what global health was according to 4 different eras. And he described global health 1.0 as tropical medicine, which began as an effort to keep white men and subsequently the labor force in the tropics alive. And then it transitioned into Global Health 2.0, which was described as international health. And it's about clever and often rich people in rich countries helping poor people in poor countries. And then Global Health 3.0, which is about people from high-income countries leading health programs and research programs in low and middle-income countries. And then Global Health 4.0, which is about people in low and middle-income countries leading health programs in low and middle-income countries. And in a certain sense, I think these definitions are truthful, even if it's a caricature. But I found that they say nothing about the how and why of global health, except perhaps for Global Health 1.0, tropical medicine, which has a very clear goal of keeping people alive, often through the discovery of drugs and vaccines and R&D issues that Julio talked about in the first talk in this session. I wondered, for example, the difference between Global Health 4.0 and everyday public health in low and middle-income countries, or whether everyday public health in these countries is only global health when the funding or the support comes from high-income countries. But even then, when I looked at formal peer-reviewed publications about what global health meant, I was just as disappointed about how little it said about the how and why of global health. So for example, much of the definitions you'd find would have those 4 points that I have up there. We'll talk about working towards health equity everywhere, which I think is right, and I often would define global health by its goal of equity. But how? And that it requires a multidisciplinary approach, yes, but to do what? And that it's about issues that transcend national boundaries. And I wasn't so particularly sure of this. Do global health issues necessarily transcend national boundaries? I wasn't particularly convinced of that point in that definition. And that there are issues that require global cooperation. Again, I wasn't so sure. But well, even if they did require global cooperation, how and why should those cooperations work? And in fact, when I think about the limits of what global health is, I often feel, I felt that I found it particularly difficult because I was born and grew up in a developing country. And that perspective meant that I looked at global health from a global south perspective. My mother, for example, was a midwife in a relatively small town where we grew up, and she had 2 separate practices. One was as a nurse midwife in a federal government teaching hospital where she received her salary. And then she had a second practice, which was essentially a pro bono service in the community where she provided antenatal care, etc., to people. And I wondered, was she doing global health when she was doing all of that? And then, of course, I had to ask myself, what if a Belgian nurse or a Belgian missionary was in Nigeria doing exactly the same thing? Would we say that they were doing global health? Or, for example, is the healthcare of disadvantaged groups in high-income countries, for example, Hispanics and African Americans with high rates of HIV, is attending to that global health? Or is looking after indigenous populations in Australia, where I live, or in Canada, would that be global health? And I have received papers submitted to the journal addressing these sorts of issues. And I realized that I didn't find a lot of problem agreeing within myself that they were global health issues. And I'll try to explain why as I go along. And these are important issues, I think, not just for a journal editor who is trying to define a field or mark the boundaries around what is publishable in their journal or not. But I think it's also important for all of us who work in global health. I think we need to be able to articulate clearly what it is that we do, the how and the why included. Otherwise, we don't really know what we are doing. And I thought, that it's important to be very clear. And if anything, that lack of clarity for me about what constitutes global health tells us that global health is really a collection of problems. And that those problems have to be defined by what is peculiar to them. That global health has to be defined by what is peculiar to those problems, the nature of the problems that global health tries to address. And Paul Farmer and his friends, including the current World Bank president, Jim Kim, in their book, Reimagining Global Health, described it as a collection of problems that turn on the quest for equity. They emphasized its multidisciplinary nature and insisted that it is neither a standalone discipline nor a specialty. And this has been my favorite characterization of global health so far. It makes no pretenses about global cooperation and national boundaries. But the more I think about these problems, the more apparent it is to me that there seems to be 2 different kinds of problems. One that is tangible and the other that is quite less tangible. Let's call them sort of type 1 and type 2 problems, T1 and T2 problems. So the T1 problems are problems in global health. Problems like developing a vaccine or drugs against infectious diseases like HIV, malaria, and Ebola. Or finding out how best to use non-physician health workers in service delivery. Or conducting large-scale randomized controlled trials of drugs and other interventions. Or figuring out how to work the logistics and strategies to respond to epidemics and disasters. Now, each of these problems is the domain of different specialties. And I think this is the sense in which global health is multidisciplinary, in that there are different disciplines focusing on different problems that make up the bag of problems that is global health. But the more you think about these disciplines, the more you see that the disciplines responsible for these problems will exist without global health. In fact, many of them predate global health, and they will exist without it. So, and I think this is a particularly important distinction to make, that the disciplines that make up the problems that global health tries to solve predate global health. So in a sense, they can't, the problems that they solve, I argue, cannot be the problems that define global health. But when we look at type 2 problems, which I describe as the problems of delivering global health, and these are the problems that you encounter when you try to deliver solutions to type 1 problems in disadvantaged settings anywhere in the world. It is when you try to address T1 problems in these sorts of settings that they truly become global health problems. T2 problems are less tangible than T1 problems. You can think of them as governance problems or as software problems, when T1 problems are, in a sense, hardware problems. And I tend to think of T2 problems as information and motivation problems that stand in the way of delivering solutions to T1 problems. T2 problems highlight the need to ensure that governments, NGOs, the private sector, service provider, researchers, communities are willing and able to put in place and demand strong and equitable health systems. Unlike T1 problems, T2 problems are central to global health. And I think, in a sense, T2 problems are extra-disciplinary. I think of them as problems that we all in global health, no matter our primary home discipline, these are problems that have to be at the center of our attention and our thinking if we want to truly justify that we are doing global health work. And why so? Well, I think it's because what defines global health really is that solutions to T1 problems are delivered at a distance, such that the context in which the interventions are to work is often far removed from the realities of the people who are governing its delivery. And please note that these are, the distance is not just in the sense of geography. It could be an economic distance, it could be a gender distance, it could be a cultural distance or an economic distance. In other words, these are not just problems that characterize the relationship between high-income countries and low and middle-income countries, as we've often thought about it. These problems also exist within high-income countries, like Patricia discussed with the example of the UK, and they exist in low and middle-income countries as well. Information and motivation problems occur across all sorts of boundaries and barriers that divide people. They occur when people with resources to address T1 problems do not have the information or motivation to tailor them to local circumstances. They occur when feedback takes longer or does not happen at all. And this is in part because the end beneficiaries of global health interventions are often unable to hold the deliverers or the implementers of those interventions to account because of power and information asymmetries. Again, these are type 2 problems, and I believe that they define global health. But I also found another dimension to the information problem in particular, and which I call the information paradox. And here goes. On the one hand, the only thing that the helper in global health, so the person who comes with an intervention to deliver, the only thing they have that the helped do not have is power and resources. In many instances, the helped, in this case, often have a lot more information about how to get global health implementation right. They have a lot more information about how to intervene in their lives. But I think we do not take this sense of our own ignorance seriously enough. And on the other side of the paradox is the notion that the people who are being helped in global health also often do not have enough information to help themselves. For example, information about how households and individuals and communities could adopt better health practices. And far more importantly, information with which to hold the people governing them, whether it's government or service providers, to account. And what this paradox tells us is that we in global health have to be both attentive in receiving and using information from the ground. And we need to focus on channeling information back to the people to help them hold their governments and service providers to account. Otherwise, if all we do is think about T1 problems, if all we do is try to deliver solutions to those problems, we are like the proverbial person who gives a man or woman a fish rather than teach them how to fish. So the first paper that I commissioned when I was as editor-in-chief of BMJ Global Health was one in which I was asking the authors to try and help us think through what exactly is global health. And I made sure that these authors were all people from low and middle income countries. And in it, the authors put forward what they described as their philosophy of global health, which they termed boundary spanning. In their words, boundary spanning requires a mindset of inclusiveness, awareness of, and respect for different coexisting realities. They added that global health practices must actively span and disrupt geographical, geopolitical, and constituency boundaries, that they must foster learning networks and communities of practice and build local and national institutions in low and middle income countries. One example of such an initiative they gave was the Emerging Voices for Global Health that was mentioned when I was being introduced, and I'm a very proud member and beneficiary of that initiative. Their argument in that article was that we have to make sure that the rules that govern how global health projects are conceived and implemented and evaluated are both mutually made and negotiated and renegotiated across divides. And the divides could be between the global and national levels, could be between the national and subnational levels, and could be between the subnational levels of government and communities, or even between NGOs and any of these categories, or even between any of these categories that I've mentioned. The idea is that we need to span boundaries and connect whatever we do to the realities that we are trying to address. So what do all this mean for global health? First, I think it's important to highlight that we've, I think, been looking in the wrong places to define exactly what we do. We need to make T2 problems central, make them shape and frame all that we do. We need to define global health in terms of those problems. We need to constantly ask ourselves the questions, how is my research or practice addressing or responding to the information problem? Ask the same thing about the motivation problem. We don't all have to be activists, and that's not what I'm suggesting, but we can all be more responsive and more respectful of the realities in which we work. And I think we can begin to think of decolonizing the idea of global health by being aware of the things that we really do not know, by being aware that people understand their own lives better than we ever could, and by being aware that they and only they really can improve their circumstances. At best, at the very best, we can only be enablers. Once again, I say decolonize, and I do not mean that in terms, again, of just the relationship between high-income countries and low-income countries. There's a lot of colonialism going on within our countries, low and middle-income countries. And those of us from those countries who are here and who often do global health research belong often in a higher socioeconomic class, or sometimes a different ethnicity or religious group compared to the sort of communities in which we work and the sort of communities that we study. And we often are in a position, and often do actually, perpetuate the sort of colonial attitudes that we complain about as coming from high-income countries. And because I happen to be a journal editor, I also wonder what sort of thinking through global health through this lens means for global health journals. Editors of global health journals are often called upon to make the decision as to what is good global health paper or good global health research. What makes a research piece great or exciting. And I've often realized as an editor that I've needed some sort of marker of quality that's different from the markers of quality that define the different specialties or disciplines that feed into global health. And one marker of quality that I've been thinking about a lot recently is that research work and publications need to be framed in terms of how they respond to and address this information and motivation problems in settings where the research is conducted. I think all of us in global health should highlight the so what of our work in our papers. How do the findings of the study that we've conducted going to help people hold their governments to account? Or how have we had to change our research question in response to the realities we found on ground that we did not anticipate initially? How do we interact with our funders to convince them that the sort of problems and sort of issues that we need to address are different from the ones that are their priority? And I find increasingly that the papers in which I find this sort of information and insight are not the traditional research papers that are trying to look for the evidence for an intervention or not, but papers that describe implementation processes, which I find particularly interesting. And I've often wondered in what ways global health would be different if people from low and middle income countries were those who wrote global health textbooks, if they were the ones who defined what global health is, and they were the ones who studied and practiced it and determined how those are done. My guess, and I hope it's yours too, is that it won't be primarily about the global commissions and the discussions and debates that are held in Geneva and New York and London, and these days increasingly on Twitter. I think it will be about the information and motivation problems, right from the most local of levels. Why things are not the way they should be in their countries at the most local levels. How it is that they can't hold their leaders to account and get the best quality of services and of public goods are the sort of issues that I believe will define it if people from LMICs are those who define these sorts of issues. And in conclusion, I want to reiterate that to do global health is to trespass, because we are intervening in the lives of other people, and we need to do due diligence. And we can only do due diligence by thinking clearly about the problems we are actually trying to address, and by doing everything we can to channel our resources and energies into working and listening across boundaries. No matter how we label what we do, whether it is tropical medicine, international health, Global Health 3.0 or Global Health 4.0, these, I believe, are the things and the values and the concerns that should define the work that we do. Thank you very much.
Thank you very much. Thank you very much. We invite to the three speakers. Julio, Patricia, can you come in? There are some microphones in the auditorium, and you can make short questions and comments. Please identify what country you are coming, and then we start this discussion. We have a few minutes to close this. Please.
Thank you. Thank you. Really, three excellent talks. Two questions, if I may. One for Patricia. What do your message means for what we call in clinical trial the world, the sponsors, the people and the institutions that take eventual responsibility legally, financially, morally, ethically of research protocols, also in social science? I make myself clear, if you want to do a clinical trial per se, you have to adhere to a lot of regulations and controls, but I see that if we do social science, there is actually no regulations or no, and I don't say that everything has to be heavily regulated, but for instance, the concern for your employees is really a problem in the kind of social science, not just the moral dilemmas they face, but sometimes also physical dilemmas. And you are responsible as a sponsor. So do you think it would be possible to issue at some point a kind of guidelines for ethical committee and managements that would address the problems and the threats to both the interviewees and the interviewers? And then my second question is to say, why don't you discard the term global health if it is so poorly defined? I think it's a new bottle for rancid old wine, and we should recognize that. Thank you.
Thanks very much for that question. I think the idea of guidelines is quite appealing, I think because it gives people a set of things that they have to think about. But lots of clinical trial researchers will say they actually have quite a lot of guidelines they have to follow. So I think any guidelines would have to be flexible to those specific conditions. Not all research requires the same thing. But for example, we've seen recently the attack on field workers, for example, in South Africa, women field workers sent out at night to collect data, you know, being raped and attacked. This is a quite extraordinary situation, and I think because of social media, because we have access to that information now, we know that these things happen. So the question is, you know, in the absence of guidelines, what are researchers actually doing to think about these things? I think guidelines are really important, but sometimes they can remove the actual thinking. And what I'm trying to promote in my work is to get people to actually engage with the features of the data that they're asking people to collect. So guidelines can help me stay in London and think that things are happening in the global south, but actually what I'm saying is that you need to get your hands a bit dirty in the data stage and work out what is going on. But I think you're right. I think having some sorts of rules and things that people have to think about that they're held accountable to, I think is also important. So I don't see them as mutually exclusive, but what I'm trying to also promote is that researchers think about what is actually involved in collecting data for their projects.
Yeah, and about discarding the term global health completely. I suppose I share your concern and your wish that we could discard it, but we can't, unfortunately, because we have to define what we do by certain words, and the words are always going to be problematic. But I think that being clear about what those words mean and what they connote and what they demand of us, I suppose, is what I'm trying to point attention to. And I'll just draw again, mention in the series of definitions of global health, the Global Health 4.0, which essentially talks about people from developing countries working in developing countries, ultimately comes full circle to the idea that actually it is public health everywhere with a concern for equity that we are really trying to do. So ultimately, really, I hope the day comes when we don't have to use this sort of label any longer and just think of what we do as basically public health addressing equity issues.
Yes, please.
Thank you. Peter de Vries, Netherlands. I have a question for Julio Martin. You have explained to us that GSK is bridging very nicely the connection between research, academia, and industry, and I think that's a very great project. It has also led to large outcomes, very good outcomes. But the biggest bridge is to, of course, the patient who has nothing to return on your investment. The patient very often is in another world where, if there is a drug, that drug is often being produced by small companies, even counterfeit producing companies. How do you think that a big company like GSK or this consortium that you joined with academia and research institutes, how can you bridge that problem to the patient who has nothing to offer in return? And I'm talking about, for example, repurposing drugs or reinventing old leads. I would like to hear a little bit more about that.
Yeah. So GSK is not working on repurposing of drugs. So as I said, we want to discover innovative medicines, new chemical entities. So we are not going to work on that. So we are making a significant in-kind contribution to the field. So we are investing internally in-house in these diseases. So we are not giving money to our partners. So the question is about working together to raise funds for another funding agencies. And this is applicable not only to discovery, but also to development, so to the clinical trials. And so what GSK is intending to do is to build trust around in the funding agencies that support clinical trials, clinical development, around by having a reputational pharma company in this kind of consortium. So we hope that this will help the agencies to maybe to invest more and to put more money. And the other component is to bring the know-how on selecting candidates. Maybe you're not the best in we should improve that, but I don't think that there is other sectors or other parts of the society which can do this selection better. So we are bringing very humbly our know-how to this. So, and by building this strand, our aspiration is to be able to speed up the clinical development and to raise more funds from agencies. I don't know if I answered your question. Yeah.
Okay.
Are there any other questions from the audience? I would like to ask a question to Say, because in your talk you focused a lot on information, and for me, as a researcher, and I think in all fields we focus on evidence, producing evidence, and you carefully avoided the word evidence. Can you please clarify why?
Can I make a second question related to the presentation? You know, when you say, what is the priorities? In my opinion, my concern is usually the group who make a decision are not in developing countries. I remember when they make a list of the neglected tropical disease, they make a list 14. Who make this? 15 people, 14 are not from the developing country. That is, in my opinion, this is unfair because we don't discuss the other part of the coin. And will be very important when we discuss the global health and what are the priorities. There are some paternalism. They are not horizontal collaboration. And I don't know what is your opinion about this.
Well, I completely agree with you. That's the case. Just to add a bit of example, that in the journal that I edit, for example, you'd find that the most high quality papers, of course, are papers about developing countries, but the string of authors you'd find, and often they would sort of sneak in a developing country author somewhere in the middle of the crowd of authors. And you sort of understand that what is going on there often is that these are the people who probably did some of the data collection, and often they are not typically the researchers who conducted the study. And it gives a bit of an idea into how research is conducted, who decides what is the important question, who is the person doing the data collection on behalf of those people. So these relationships are hardly ever equal, not yet. I noticed that there seems to be an appetite for equality. I could pick that so far in this conference. People are talking more and more about partnerships on equal footing, but also I also picked a lot of really patronizing language in this conference as well. So it's still going on, and I wish that appetite outshines and overgrows that sort of different levels of relationships. And to the question about evidence, I studiously avoided most of the usual terms that are used in global health and in public health even generally. I was trying to speak English as much as possible throughout my presentation and avoid all the jargons, just to communicate as clearly as possible to this audience that is a varied group of people who may not necessarily share my language. However, I avoided evidence in particular because the way in which we construct our idea of evidence is as something that is grand and applicable to a broad group of people. Sort of evidence that XYZ works, full stop. Or evidence that this is a good thing, full stop. But in a lot of global health, evidence is contextual. What is important in a community, in a state or country, will depend a lot on the sort of information you can pick up from people in those places. So if evidence then means information that is contextual, yes, of course. But if it means information that is decontextualized, I'm not, friendly to that.
If there are no more questions, then I would. My director always has questions, so please.
Very quickly add to, if you, there is a book, and okay, by now it's 10 years old, but it's a thick book which has been issued by the Gates Foundation and the World Bank, and it's disease control in developing countries. Maybe some of you know it. If you look at it, there are 9 editors, and 8 of them are from the North. I'm not using the term global North, and the 9th one is actually from the University of the West Indies. And if you look at the individual contributions, I think from the 600 or so, 1/4 at most is from people from the south, from developing countries, as they call it. So I really think we have come a long way, but there's still a long way to do, and I really would like you from the south and all the people here to, it's also your take. You have to take the responsibility and the ownership and take the risk with them. Thank you.
Thank you for that. So,
Yes, I close with one comment. Yes.
so as we would like to close and thank you, but Professor Gottuso will make the final comment. I would personally, from my own field of chenoplastid research, but then in the more downstream control issues, which I'm working on, congratulate Julio Martin and his colleagues on your work and your investment, because this partnership model indeed, not only your company, other companies as well. We have seen an example here at the Congress on fexinidazole, which is really good news in the field of sleeping sickness control. And I think for these most neglected tropical diseases, where there is no market at all in the north, there is no other way, and there will never be a market, soluble market. So, but I thank also Peter to share that the real issue is the access afterwards to those drugs, and that has been highlighted in the Congress. So.
Yes, I would like to make an additional comment.